Hi, this is Dr. Bob Dannenhoffer with another of our Facebook Live events. I'm sporting a new balaclava here, but I'm going to take it down so those who read lips can see what I'm saying. So again, Dr. Bob Dannenhoffer here with another of our Facebook Live events. There's lots of great new stuff that I want to talk about tonight, some which is really good stuff, some which is a little disappointing. But overall, I think there's lots to learn about COVID-19. So we'll take your questions. Just go ahead and put them on the chat section, and our people will put them on cards for me, and we'll get to it. So as we usually do with this, we'll start out with the situation. So in the world, COVID-19 is still increasing at a very rapid rate. We're now over 3.4 million cases and 240,000 deaths. So at this point, we're past the average flu season, and we've just been into this 6 weeks. So this really is a bad disease, and it's still continuing to spread. You know, every week, every night I look, there's another 30, 40,000 cases in the world, and that really has not slowed down very much over the last few weeks. Still, lots of cases in different places. We're seeing this week lots of cases in Brazil, Russia, and Peru. Who'd have guessed? But these are three areas that are starting to have lots of cases and many more deaths than we would like. In the U.S., we're over 1 million cases now and over 66,000 deaths. 66,000 deaths is a lot. You know, that's more than we lost in Vietnam, as many as we lost in Korea. So it really is a big deal, and we're not starting to see the decline in death that great. So although New York has had a stabilization in the death rate, New Jersey has stabilization in death rate, we're still seeing high death rates in California and other places. So we're clearly not done with this, but there are some good signs. In Oregon, we've been really very stable over the last 2 weeks. And in Douglas County, we're at 6 active cases, which is our lowest case rate ever, only 1 person in the hospital. So we're doing okay here in Douglas County. Still, with 1 person in the hospital, we're very worried about him. But overall, we've not had the big explosion of cases like other places in the world have had. So send us your question. We're going to go ahead and do it. So one of the things I did want to talk about is we do have a new case. And can you tell us how the new case could already be recovered? And this is talking about antibody tests. Remember, I said antibody tests will not be particularly good for screening wide populations, but they'll be very good for looking at people who might have had the disease and for whatever reason didn't have a test. So this individual was sick a month or so ago, did not have a test for whatever reason, but then when he saw his doctor said, well, this might have been COVID, you might get a blood test. So the antibody test was done, the antibody test was positive, and since the antibody test was positive, we recommend that he get a nasal swab, and the nasal swab showed that there was still some RNA in his nose, and so he's a case. And so that's how, but his symptoms were already recovered by the time he got the antibody test. So he's already recovered, but is a new case. Now, we do know that the RNA material can live in your nose, can be in your nose for a long time. We did find out today that in almost no case is it living in your nose. It's like just being in your nose. So it's sort of like the dead bugs on your windshield. These things stay for a long time, but they're not alive. Similarly, the bugs in your nose grow for the first. In no cases were we able to recover viable virus after 9 days. And since it's well past 9 days, this is presumably not viable virus, but the RNA is still there. So that's the good news. We think we're going to get more of these. So again, the antibody test, let's talk about more about that. So the antibody test, there's 2 kinds of antibody tests. One is the lab antibody test, where the labs do these like they've traditionally done antibody tests. We think these are pretty accurate. The Mayo one is over 98% specific. The Quest one in that same range. The Mount Sinai one, even better than that. So those are pretty good tests. They also have these little home tests that look like home pregnancy tests. Those have been really, really disappointing. We were hoping that those would work so you just go to your doctor and figure it out, but they have not. They have been disappointing in their both sensitivity and specificity. So somebody talks about the Logic Smart Corona-19 test kit, claims 100% sensitivity and specificity. Well, don't they all? The story is that the tests that are now approved under the FDA emergency use authorization do not require anybody to verify that. So it's not surprising that people say, oh, our test is great. Now, this is a PCR test, and the PCR tests we think are 100% sensitive and nearly 100% sensitive and nearly 100% specific if given virus perfect sample, which is a sample that either has or doesn't have virus. Now, the test that we're doing in the nose, we think has also 100% sensitivity and specificity if you're able to get viral material on the swab, but because you're sticking this viral material in there and you don't know what you're hitting, it's not great. So then Sylvia asked the follow-up question, is that doximity saliva test more sensitive than nasopharyngeal swabs? We would really hope, because you remember what I wanted for Christmas, which was a saliva-based test. Until now, we don't think they've been more, although this group did report that the saliva tests were as good as nasopharyngeal tests. These people have something to sell, so I would wait until somebody else verifies this. But boy, a saliva-based test would be so much of a change, right? Right now, I'm going to Reedsport tomorrow to do these swabs, and I can tell you, I hate hurting people, but when you do this, these are really uncomfortable. And so if we could do this by spitting in a cup, everybody could do that, and you wouldn't need me dressed up in my moon suit to get it done. So I'm hoping this is true, but unfortunately, in the past, when they've approved a test or a drug, the FDA looked at this, had a long and very rigorous process, and you couldn't claim anything until it was proven. And they would want multiple studies in multiple different ways, conducted in different sites to get it done. However, under these emergency use authorizations, none of that is done. And so that there's some claims which, when tested, really aren't true. So, but I hope this one is true. So with 6 active cases that we know about, what's the current estimate of active cases in the community? And again, we don't know the answer to this. It's clearly at least 6, but could it be more? Could be. One of the things we look at is negative testing rates. So that is, if you do tests, what percent of your tests are positive and what percent are negative? Over the last month, we've been over 98% negative. So for every 50 people we test who have symptoms or want to get tested, only 1 is positive. So, if there are other positives out there we don't know about, I don't know where they are. So there may be some other active cases. Now, if you go to other places like New York that has a 22% positivity rate, clearly they're not finding every case. I don't know what our estimate is. The estimate from IHME was that that most places in Oregon probably have as many undiscovered active cases as they have really active cases. But again, we won't really know until we start doing some of these, for example, screenings of people who are asymptomatic. And there are a bunch of those going on. There's a very interesting one today from OHSU, another one from PSU, and then another one from Oregon State. So once we get that, we'll get a better idea. So do we have so few cases because we haven't tested very many people? No, that is not the reason we don't. We've tested now about 1 in 1,000, which is a pretty good rate. Plus, what we've done is we have so many negatives. Again, if we'd only tested 6 people and we'd had 4 of those were positive, that could be a reason. But I think with a 98% negative rate, only a 2% positive rate, it's not because we haven't tested many people. So will testing be available for the general public? So the testing is available for anybody now whose doctor gives them an order. We are not yet in Oregon doing testing of everybody symptomatic or asymptomatic yet. Do you think that cases that, if we're talking about the new case, could have infected others? Well, we're going to go back and do the interview, but we don't think so because there were no other cases connected with that case. So, but we'll go back and we'll do the interview and find out. So what do you think about Walgreens starting to do testing? Sure, if they want to do testing, that's fine. I mean, I have no problem with people doing testing as long as the testing is reasonably accurate and as long as people aren't trying to rip you off. What I did hear today was there's some places that are doing testing of dubious quality and charging a lot of money. I don't think Walgreens is going to do that, but I think there are others that are out there that are doing that. I think if Walgreens want to do testing, that's fine. This is especially going to be important in New York. Remember, in New York, they have not done they've done a lot of testing, but not nearly as much testing as they should, given the number of cases they have. So again, in New York, I calculated yesterday to get to a 5% positivity rate, which is what which is what I think everybody suggests you need to get to really get this under control. So, for example, in Korea, if you looked at their outbreak, once they got to a less than 5% positivity rate, the disease really started to come down. Once they got to a less than 2% positivity rate, it was gone. So I think really our goal, rather than total number of tests, is really a foolish deal, because if New York even doubled the number of tests, they still don't have enough. Right? They'd still only get down to an 11% positive rate, which is still way too high. So they need to quadruple the number of tests. In Douglas County, we've already hit the number of tests we need to have to get less than 5. We could always do more, but again, I think we really need to move the test to the places that have high positivity rates. Yeah, so Crystal says, I see a lot of workers wearing their mask over just their mouths, not their nose. Is this still effective? It's about half as effective. Obviously, you get droplets from both your mouth and nose. No, we would recommend that you do it over both your mouth and your nose. And Kristen did a lovely video about how to wear your mask, and I would have you look at that on our YouTube channel. Yeah, so I see that Quest has an antibody test that you can do without a doctor's note. And the answer is yes. Actually, the Quest test is an excellent test. So if there's anybody who's looking to do it, you can do this test. We don't know how the billing on this one is going to go, so I would talk with Quest about this, because the president only promised that there would be no copay or deductible for tests that your doctor ordered. But the Quest test is an excellent test. Again, that's not one of these rapid tests. It is a test that's actually done in the laboratory, so you have to do blood work, get it sent away, and we think that's a pretty accurate test. Now, not accurate enough probably to do screening of a bunch of asymptomatic people, but a very good test if you think you had the disease. So why is Douglas County not testing anyone who wants it, even without a doctor's note? And again, it's not a doctor's note, it's just a doctor's order. And the reason is we do not want anybody to get charged for it. And if you don't have a doctor's order, there's no guarantee that you won't get charged for it. So that's doing it. The other reason we're not doing it is we want somebody to be able to follow up the results. And so that if you are positive, somebody you can talk to follow up the results. Douglas County is not a very good doctor, so we really want a doctor to order this for you. Again, as we talked about before, if somebody really wants an antibody test, you can get that through Quest. Now, antibody tests, the reason you can do those is that they don't need any follow-up. So if your antibody test is positive or negative, it doesn't change what you would do, because the antibody test would suggest the disease was in the past, so it doesn't change anything you do, and that's the reason you can do that one without a doctor's order. So someone says, I would like to visit my 91-year-old father. Would it be safe to do if I had been staying at home and never had symptoms? Yeah, is there a number of weeks to make it safe? Yeah, so my mom is 90, and I desperately want to see my mom, and so I've had this exact question. You know, could I ever go back and see my mom? And I can't think of a way. The only way that it would logically be safe would be to go 2 weeks earlier, wait 2 weeks, be sure I didn't have symptoms, get a test 3 days before the 14 days was up, and then if I was perfectly well, didn't have symptoms, and my test was negative, the chance of me infecting her would be low, but still not zero. So there is no perfectly safe way to do it. So there's no perfectly safe way. Now, if you did definitely stay home, didn't get exposed, had no symptoms, yeah, it would be safer than I just flew to visit her, but I don't think there's any perfectly safe way now. So the question is, if you have a positive antibody test, are you immune from getting it again? We don't know the answer to that. So again, there's not enough time here to tell. The WHO said in this last week that having had it before is no guarantee against reinfection, that there's no evidence that positive antibodies prevent you from getting the disease again, so we don't know. We do know from other antibodies that they do prevent you from getting the disease again. So if I have measles antibodies, I won't get measles again. Coronavirus is a little bit up in the air. One of the studies that I read last week was a study that they looked at another coronavirus, not this one, but another coronavirus back about 10 years ago. And what they did was they found 15 people who had antibodies to the virus. Now, you'd think if they had antibodies to the virus, that should protect them. They challenged these people by giving them spraying some of this coronavirus in the face. These must have been very poor medical students who were willing to get sprayed in the face with coronavirus. And of the 15 who got sprayed in the face with coronavirus, 10 of the 15, even though they had antibodies, got the disease. That is disheartening. And then the 5 that didn't get it, they sprayed them in the face the next year, and they all got it. So 15 of the 15 got it over a 2-year time. That would be really good evidence that antibodies won't protect it. On the other hand, antibody-rich plasma does seem to be helping people. So I don't know. So I think it's still up in the air as to whether antibodies will give you protection. This is important for a couple of reasons. One is that people say, well, just build up that herd immunity, get it, and then you'll be fine. But if you can get it again, that's not a particularly good strategy. And it also may suggest that a vaccine will be harder to develop. So I don't know. So one of our armchair epidemiologists, and we love to have those. So what's the R0 for COVID? So that is, how many people can get infected by a contagious person on average? So R0 is an important number in epidemiology because it tells you how infectious a disease is. So the regular flu has an R0 between 1.1 and 1.3. That means that in the typical world, one person will infect 1.1 to 1.3 people. This, we don't know exactly the R0. Now, we've calculated it 20 different times, and the R0 on this one has ranged anywhere from 2. I've not really seen a number much less than 2, up to 4.9. I don't know what the right answer is, but it's somewhere, it's twice as contagious, at least, than the flu, and maybe more than that, right? A disease like this, to go from the Teddy Roosevelt, where you had just one case and then had 600, or the Diamond Princess, where you had one case and then had 800 in just a few weeks, suggests the R0 is high. Now, the more important thing on this is the RT, and the RT is what's the contagiousness at that moment. And actually, there's a website called RT Now, and it'll tell you what the RT is in different places in different states. And RT of more than 1 means that it's going to spread exponentially, and RT of less than 1 means it's still going to spread, but it won't spread exponentially, and you can do it. So knowing the RT can really help you to know. So if your RT is much greater than 1, you certainly shouldn't be opening up. And there are some places that have decided they would open up with an RT of greater than 1. That's a terrible mistake because they could continue to have growth in that. Oregon's RT is less than 1, so I think we're on the track to opening up. So CF asked, with 4.2 million people in Oregon and only 104 deaths, mostly elderly with underlying conditions, do you think the shutdown now is not acceptable? It's destroying people's lives. Yeah, this is a tough balance, right? Because if you are the son of one of those 104 elderly people, or this is your mother, or this is your spouse, it's probably not acceptable. And so this is a tough balance of the havoc this is creating in society with the economy, the havoc that this is creating socially, and then this. I spoke at the press conference earlier in the week, and what I said is, as public health, we could say we would keep the lockdown forever because we wouldn't want any cases, but you have to balance that against what is going on in the economy. And so I have promised economists that I would not do economics if they won't do public health. So what I think politicians need to do is to listen to economists and listen to public health people and try and get a good balance. Actually, I think Oregon has done okay so far with the balance. But this is a tough question. I don't know what the right answer is. People say, well, we only had 104 deaths, but we only had 104 deaths because we did what we did. I think if we had done nothing, we would have seen the same kind of explosion you saw in other places that did nothing and see a death rate which is much higher. So one of the big darlings in this week has been Sweden, which has not done very much for lockdowns, but they have a very high death rate. And I don't think they're close to their peak of death rates. So they may wind up with a lot of deaths. And that's a societal question of how many deaths are we willing to accept by the things that we do. And we make these decisions all the time. We don't let people drive 135 miles an hour on the road, even though cars would probably go that fast, because we know that there are more deaths on the road. And so we've kind of decided that 65 or 70 is the right speed. We have decided that drugs can get approved even if they have side effects, but we certainly wouldn't want thalidomide back again that had a lot of deaths. So this balance between life and safety is a tough one, and I don't know the right answer. I think we've done okay so far. I think we've done okay. I think it's time that we could loosen up a little bit. So can I explain the phased opening? I wish I could. So a phased opening would suggest that you don't do everything at once. So right now we're small gatherings, lots of businesses that are closed or doing something different. A phased opening would suggest you would do things slowly. So for example, it would suggest in states that have done this, they've opened restaurants to 25% of the seating they had before, or they've opened up businesses to have people only have certain amounts of social distancing. So that's what the phased opening looks like. The president had a plan. Actually, the plan came out 2 weeks ago today, and that plan actually sort of has a good outline of what phase 1, phase 2, and phase 3 would look like. We're not really back to normal, though, way past phase 3. So, if we're talking about sports, big sporting events, international travel, we're a long way off from that. So do we have any info if this virus is changing, Micah asks. And the answer is I think we do. So we knew about what the genome of this virus was, the exact genetic code within a month or so of this virus being identified. So we've gotten so good at finding DNA now. It used to be a really complicated process. So when I was in medical school, to find the DNA of one gene took forever. Years and years of research, and now you can do it in the space of a day or two. So we've gotten so much better. So what they've done is they found the virus in different places, and they can find that the genetic fingerprint is different. So it is changing, not changing very fast though. So it's changing enough so they can sort of find out where it comes from. So they think the virus on the West Coast in the U.S. probably came from China. They think the virus on the East Coast likely came from Europe, which came earlier from China. And so it is changing a little bit, and that's helpful to do it. Now, if it changes too much, it makes a vaccine really difficult to build because it changes so much. We don't think it's changing that much. So in the whole scheme of things, HIV and influenza probably change the most. Measles probably changes the least. This is somewhere in between. So Gabriel asks, how long in years, if applicable, will we need to do some level of social distancing? So this is the Bob Dannenhoffer guess. There are lots of people out there guessing too, and I don't know the right answer. So this is going to end in one of several ways. Could end with a very successful vaccine. Then that's likely to be, if that works, that would be in a year or so that we'd have a successful vaccine. So that would be a good thing. So that would be social distancing for a year or so. It may end with a really blockbuster therapeutic. We'll talk about therapeutics later. But it might end with a blockbuster therapeutic that would just nip it in the bud. And if you get something that would just nip it in the bud, so it would be bad to get it, but you'd go in, take the magic pill, and you'd be better. And then it wouldn't be much of a deal, and we could probably go back to the old ways. We could have a preventive medicine, so there might be a medicine you take every morning which will prevent this virus from spreading in your body. That would be great. It'd be pretty expensive probably, but it would be great, and we could likely do it. So I see one of those three things may be happening, but I don't see any of those happening in the next 6 or 8 months. So I think we're going to be at least a year or so, at least of some social distancing. Now, the hope would be that we get to the point where we get to a more normal life, still with social distancing. Are we going to be shaking hands again? Fauci thinks we never will. We probably won't. Are we going to be thinking about going to a Blazers game? Probably not soon, but hopefully they'll play sports at least. Yeah. So Allison says, what are your thoughts about opening up and then having more people from more infected areas coming to our county and spreading it? This is clearly a risk. So clearly a risk in the world is that people will travel from a place where the disease is more or less common and spread it to a place where it is less common. And so, this is a risk. So at one point, we worried about people coming from China because they had much more disease than we did. Now China worries about people from the U.S. coming to China because there's much more disease in the U.S. than in China. So it's going to be a constantly evolving thing. We have closed the borders, so I don't think people are coming from outside the borders to come to the U.S. But within states, we have not started restrictions. So we don't stop people at the border to Douglas County and say, what county have you come from? There's still free travel up and down I-5. And so that if we do open up, say in Southern Oregon or in Eastern Oregon, there's nothing to stop people from Portland area coming to our area. And that's one of the risks we need to take. And again, one of those balances of freedom. I don't think I'm ready for a checkpoint at every county's border to see where I'm coming from. So this is that balance that you take. Yeah. So Anthony says, why has CDC requested that hospitals categorize death as COVID-19 when it may have been other contributing factors, in some cases with no relation to COVID? So I saw those rules out today. It's not exactly that, but there are going to be a lot of cases that are going to get attributed to COVID, where COVID is happened in the 60 days before death, but COVID may not have been the cause. So the way the new rules say that if COVID is diagnosed or presumed in the 60 days before you die, and there's no other better explanation, and it's listed as one of the contributing causes, then it'll be a death that's associated with COVID. That's not unreasonable because that happens with other diseases too. So if you had salmonella and then died within 60 days, one of those deaths might be attributed to salmonella. This is how we do flu. And so when people say, oh, there's 60,000 deaths a year from flu, it's 60,000 deaths a year because some of these are old people who have the flu and within 60 days die of the flu. And so that flu is put as a contributing cause, and that's where you get that number. So this is going to obviously up the number of deaths. And whether you can absolutely say it was from the COVID or whether they had COVID and died of a car wreck, maybe not. So, but this is not unusual with COVID. So we're not doing something different from COVID than we've done with other diseases. And I think what you'll see is the death rate will climb, but I think it'll be more appropriate. Now we have noticed in areas that the overall death rate is increased. Many people had respiratory symptoms. We in Douglas County are swabbing them from COVID. I've not seen any, but there are probably some. So Ryan asked, well, how many coronaviruses do we have vaccines for? I think the answer is exactly 0. I've been trying to find an effective vaccine against the coronavirus in any animal or species, and I don't know of any. So Ryan, if you know of any, let me know. So Ryan says, when will we likely have a vaccine? So there was a long talk last night about vaccines. And there's some really fascinating stuff about vaccines. And so if you look up mice lie and monkeys exaggerate, there's this talk by Paul Offit that talks about vaccine development. So he's a guy that developed a lot of vaccines and worked with a lot of vaccines. And he gives sort of a sobering view about vaccines. And the story with vaccines is that vaccines are tricky to make. And there are some things that we've tried for a long time to make vaccines for, HIV top among them, but herpes, strep, all kinds of things that we've tried to make vaccines for and have not been successful. And then other things that we've been very successful for, like Hib, which is this Haemophilus influenza B, which is a terrible disease in kids that we've nearly wiped out with vaccines. So vaccines are all over the place, going from, can't seem to do it to really wiped out a disease. So when I was a resident physician, a young physician, this Haemophilus influenza B was terrible. Every day in the emergency room, we would see kids come in with fever and you do spinal taps and blood tests and whatever. You couldn't tell who had it and didn't, and did it, and it would cause meningitis, it would cause facial cellulitis, it would cause osteomyelitis, it would cause pneumonias, and it was just a terrible disease. And then in the 90s, we started coming with a vaccine, and by 2000, we had a very effective vaccine, and in the last 10 years, there have been no cases of Hib disease in Oregon. So it has been such a great vaccine, and that's what we're hoping for here, but I don't know. There's certainly good likelihood. There's certainly all the great minds in the world are working on a vaccine for this. So I think if there's any chance we'll do it. Dr. Fauci still thinks it's going to be a year to 18 months from when he first said this in February. So, perhaps it'll be as early as 9 months from now, which would be great. But vaccine may or may not happen. And then the question is, does this vaccine then give you protection? Do you need to repeat it? How long does it give you protection? How effective is it? This would all up in the air. But I would do that. So Cheryl says, what do I think about Remdesivir? It's hard to say. So Remdesivir is an antiviral drug that was developed to treat Ebola. It did not work. Remdesivir has now been tried for COVID, and there are a couple of studies. There was a Chinese study that was a blinded controlled study that suggested it didn't help very much, and Remdesivir went down, and then there was some stuff that it went up. There was a recent study that was talked about a lot yesterday that showed that it did seem to help, although I think everybody suggested it wasn't a home run. It decreased the length of hospitalization by 4 days, which is great because nobody would want to be in the hospital, so that's great. But it didn't decrease it to 1 day, and it didn't change the death rate, as I can tell. But again, a lot of this, what's happening during this, which is really disturbing, and there's so much leaked information about these studies. Now, when you're in regular times, I do a study, and I am absolutely forbidden to talk about this study until it's peer-reviewed and published. And so by the time you hear about the study, it's been carefully looked at, it's been published, and you can pretty much test it. During these times, what's happening, there's so many leaks about these studies that are coming out before they're peer-reviewed and published. And they're very disturbing because people are leaking information that may help or hurt or whatever. So I really want to see the full peer-reviewed study about what this is. But it's the one bit of bright hope that we've had about drugs. Yeah, so Sandra asked, do virologists know yet if this virus is going to be like influenza, where there's a new strain every year to get vaccinated for? And we do not know the answer to that, although we don't think so. The way that influenza works is that influenza has several different parts to it, and it usually takes a combination of people, pigs, and birds. And what happens is the viruses circulate in people, birds, and pigs, and then get recombined and then go back to people and cause a disease. So that's when you hear about flus, they're mostly avian, bird, or swine, pig, flus that then cross over to people. So there's a well-established way that these viruses switch between these three species. And that's why it's not uncommon that these viruses come from China, where a lot of people, a lot of pigs, and a lot of birds live in close quarters. We don't think that's going to happen with coronavirus. We think this is a one-way transmission from bats to people, and we don't think it's going to go from people back to bats and back to people. So we don't think it's going to be that, but we don't know. So if I think I had the virus 2 months ago, what test should I get? You should definitely get the antibody test. And I would recommend that you get an antibody test through a place that, through a regular lab. I think the Quest Lab one is good. The Mayo Clinic one that they're doing over in Coquille is great also. So, so if you think you had it 2 months ago, you should get an antibody test, and you should get one of the ones done by one of the big labs. So the question is, where did you get your mask? Is it circular? Tammy asks. Yes, it's called a balaclava, and it is circular. It goes around my neck. And so it's great. I put it on in the morning. I never have to worry about it during the day, and I can put it up without touching my face, right? So I touch the sides here, but not touch my face. And so it's just become part of my daily thing. This one actually matches my shirt pretty well. But you can get them. They're about $10 on Amazon. And so I've got like 10 of them now. And so if other people want to get them, that would be great. So Lori asks, if school starts again this fall, and I think it probably will students be expected to stay 6 feet apart in schools this fall? That's going to be really hard. I had a long email trail with the superintendents yesterday about that. I don't know what the answer on that's going to be. School's going to be really hard, right? Because especially in little kids, enforcing social distancing is not easy. Most classrooms are good size, but not enough size to have good social distancing. So I don't know how we're going to do that. Are we going to go in smaller, like 2 shifts a day, where you only have now 15 kids in the room? Maybe, but then how do you do the buses? How do you do recess? So there's lots of questions about how we're going to do this. In other places that have opened up, they've not opened up until the virus was nearly gone. I don't think we're going to get to there in the United States, so I don't know what we're going to do with school. So can a county open without the state approval, Scott asks. Well, the order to stay home and stay healthy is a governor's order and the purview of the governor, and only the governor can change that order. Now, just like there are no social distancing police and infection control police, there's no I opened my barbershop police, but we really need to sort of be in this together. Counties in Oregon have been incredibly good at this. None, as best we know, have violated the governor's order, which is great. Now, you'll have to actually look at the governor's order. People have misinterpreted that. I get 10 calls a week about essential and non-essential business, and the governor's order didn't even talk about essential and non-essential businesses. It said that there are certain businesses that should close, but left a wide range of businesses that could stay open if they could do adequate social distancing. So at least in Oregon, a county cannot open without the state approval, and we certainly don't want to test it. So are there any plans on testing kids? I'm worried that they're asymptomatic carriers. Nobody has figured this one out. So yes, kids may well be asymptomatic carriers, right? Because kids, when they get this, are much less likely to be symptomatic than adults. And they could be asymptomatic carriers in doing it. Now, I will tell you that in the virologists who look at this, we talk about asymptomatic spread. I think there's this emerging consensus over the last 2 weeks that there isn't very much asymptomatic spread, that most of the spread is pre-symptomatic. So again, there are people who get this and don't have any symptoms. But then there are people who have it, don't have any symptoms yet, and then develop symptoms. And then when they've looked at the super spreader events, all of those people were pre-symptomatic. Now, it would be hard to know if asymptomatic people were involved, but they don't really have any examples of big spread that were later found to be related to asymptomatic people. They seem all to be related to pre-symptomatic people. So I'm not sure. Now, if the test you have to do is to stick this swab deep into their nose, there aren't going to be very many kids who are going to let you do that. And that's the reason we've not tested kids in our drive-thru, because I will tell you, you are going to have to hold kids down to get this done. And then if you're going to screen them asymptomatically, remember, we think the rate among asymptomatic people is less than 10% of what it is in symptomatic people. And since our rate in symptomatic people is only 2 in 100, it would only be 2 in 1,000 in asymptomatic kids. That's a lot of kids to hold down. So I don't think we're going to be with testing the way it is now. Now, if you had a quick saliva test and kids got to spit, every kid in the world would want to take that test. So we'll see how that goes. So the question, Linda says, is Mercy doing elective surgeries? I think starting in this next week, they're going to start to do some slowly and gingerly, exactly as was recommended. They've got adequate PPE. I talked with Jason Gray the other day about this. It was really, it was great. They have a really good plan to get it done. So I think they are going to be starting over the next few weeks. The concern is that people who've had stuff that's really kind of needed hasn't been getting done. And so this will get a chance to get those done. So what about ozone generators to disinfect areas to kill the virus? Does it work? So ozone generators do work. So ozone is O3, like oxygen is O2. O3. So it's like an oxygen molecule with another oxygen molecule on it. And it is toxic. Ozone is the kind of smell that you smell after a lightning storm. It's got that kind of spicy smell. And ozone generators can work to disinfect an area, but it just disinfects an area. It doesn't really disinfect people. And so, for example, we could use these in a hospital ICU after somebody left to go ahead and disinfect the room so somebody else could use the room. But in general practice, not all that helpful. Yeah. So Ryan asks, you listening, what happened to the serology study in the hospital system in Portland? Results were supposed to be released last week. Very interesting. They did their antibody study, and what I heard was the results were so unbelievable that they took them back to get done again because something didn't seem right. So this is why I don't like to get leaked studies, right? Because the leaked study may have, and I don't know what the results were, but the leaked study may come out and suggest something really misleading. But then when you actually look at it, they say, that was the problem. We did this, that, or the next thing. So it's still not out yet. I'm dying to see what it shows. So is prolonging social distancing weakening our immune systems? No. So our immune systems are really strong. Actually, what tests our immune systems most are the normal germs we come up with every day, right? So there's germs on everything we touch and eat. Almost none of the food we eat is sterile. And so our immune systems are constantly being challenged. We don't think social distancing is going to make a difference. What about herd immunity? And again, herd immunity means getting enough people immune to a disease so that they're going to be able to fight it. Again, to get herd immunity for this disease, you need to have a rate of at least 60 or 80 or 90% to stop the disease from spreading. And that seems so unlikely when even in New York, the worst hit areas, it was less than 20%. Or in Iceland, which did have a big outbreak at one point, was less than 1%. So I don't think we're going to build herd immunity to this disease. Now, that's sort of the idea in Sweden, and we'll see how their experiment works. Yeah, talking about school, how safe will it be to be in a classroom if you have an underlying condition? And this was one of the questions that I worked on with the superintendents. Let's say you have a teacher who's 64, looking to retire the next year. They've taught second grade for 40 years, and they're looking to retire next year, and maybe had underlying diabetes and hypertension, like many of us do. And the story is, what would be their risk now being in school, because one of the many kids in their class could have this and give it to them? And what's that risk? I think the risk is certainly not zero, and we're going to have to see what that risk is. But this is going to be one of the changes in society. So if you are in your 60s and have an underlying health condition, how willing are you going to be to go on a cruise? How willing are you going to be to teach in school? How willing are you to go to the grocery store? And this is one of those things that I cannot answer for people. So can people sleeping in the same room with a CPAP machine get more of their germs? Lisa asks. Actually, we don't know. Actually, we think that CPAP and BiPAP do generate some aerosols. So, for example, if you were a respiratory therapist working in a room with somebody who was on CPAP or BiPAP, we would think you should use protection as if you were having aerosols. Now, you say, well, how is that different then from them just breathing on me? We don't know, but we do think nebulizer treatments and CPAP and BiPAP might generate some aerosols, so there might be some increased risk. Okay, well, let me go over some of the things that I wanted to go over. So there was an interesting study that happened the other day. What they did is they took all the drugs that were out there, and they looked to see if they looked to be effective against this virus, either in the laboratory or just because of the way the proteins were. And they found a bunch of drugs, some of which are very common drugs, one of which is Claritin, which theoretically could be effective against this. And this was their chance to look at those drugs to see now in the laboratory, does it really work? And so this was sort of a study. This is actually what my son does at NIH, is looks at chemicals to see if they look like they might work. It's just relatively new stuff. We don't know what's going to work, so certainly don't start taking Claritin. But it was very interesting to see that you could maybe do some predictive modeling about what molecules might work. Now, some of these are drugs that are still in the pipeline, some of which are out already. There's a blood pressure medicine among them. There was a medicine that's uses to treat other viruses. And so I think this will help scientists to narrow their focus on the drugs that might work. So that was pretty good news, but that's obviously going to be a little while until it gets there. And then for people who've been looking, this COVID toes thing has come out in the last week. So COVID toes is these feet that look like people have frostbite, even though they've not been out in the cold. And that, in some people, has been predictive. So there have been no case of that on the West Coast, but on the East Coast, they've seen some of that pernio toes. And the other thing that they've seen is these inflammatory diseases in kids. These kids test negative for COVID, but in the same areas where you have COVID, where kids have had a lot of inflammatory disease. So we don't know what's happening there. So we're learning so much about this. I'm reading 4 or 5 hours a day about this thing and still finding new things every little bit. So we'll tell you as best what we know about what goes on. And again, I try not to be overly optimistic, like, oh, this is going to really work, or overly pessimistic. I hope I'm giving everybody sort of an even keel view of what's going on. But I think overall, I think we're doing a great job here in Oregon. I think we're close to being able to limit some restrictions. I'm very, very pleased at the work that everybody's done together. We've gotten some criticisms, but not so much criticism of what we've done. And people have really done a great job, so good luck. So, do we have one more question? Okay, I think we did it. Again, this is Dr. Bob Dannenhoffer with another Facebook Live. We're going to do this again on Monday. So if you have questions between now and Monday, please let us know. If there were some questions we didn't answer today, I'll go through those tonight and try and get you an answer. We're going to do another set of tests tomorrow in Reedsport, and then we're going to do some more testing here next Tuesday. We're going to do another Facebook Live on Monday night. We'll see you then.